But one of the things that we really want to stress is the variance in a verbal and a nonverbal IQ. There are some people who say, nope, we don't do that. And this is why. My personal background training through developmental pediatricians' offices has influenced my opinion about that. I've seen the relevance and the difference when we're able to scale those verbal and nonverbal IQs, and I'll give you an example. Not too long ago, we had a client who was in the middle of a court case. The school district labeled their child intellectually disabled. He had an IQ of 65, 64 on the verbal. Did not give a nonverbal IQ. They don't give nonverbal IQs in a school setting, and this is across the board as far as I know, unless any of you are from a district and can tell me different, please. And I've worked with almost, I would say, Comal, Northeast, Northside, Bernie, just SAISD. They just, go ahead.
I'm not sure it's fair to say that we don't give nonverbal IQs in the district, because I think there's a lot of variability in our assessment, and we do give nonverbal intellectual assessments quite often. Some very big ones that are very commonly used.
So across the board, it's not a consistent standard that they give those. I would love for them to do that. The conversations that I've had with many school psychologists are that that's just not what they do. They give the verbals, and these are most of the larger districts that we've worked with and that I've worked for. I'm hoping that that will change. Going back to this case was that missing information, because the child struggled with autism and didn't have a lot of language skill, he did perform very low and had a very low IQ based on what they gave him. And the courts ruled in the favor of the family because that missing component didn't show his ability level, and his whole educational placement was based on that score. And so the schooling that he was given was not accurate in this case. And I know that different campuses, again, going back to what I said earlier, depending on what the school allows, and some are great about having bigger budgets or having more training and all those kinds of things, but it's not been something consistent. It is something that we highly recommend to be able to take both of those scores and check to see if there's a gap. We're looking for double digits, mostly a higher double digit. So if it's 20 points difference, 30 points difference, we've seen it as high as 40 points difference, that's pretty significant. We're gonna have 10 or so points difference, just typically. But when you're looking at a larger gap, a double digit heavy duty gap, that's one of our first cues to continue exploring that area. And the bigger two, I would say, are the SRS and the Autism Diagnostic Observation Scale, which again is not, let's say that they scored yes and there's enough of a scoring that does designate that he or she does have the traits. That in itself does not prove that. You're taking all of these things into consideration. When we've gone to the trainings and they're doing the live demonstrations of the trainings that are being done, they'll emphasize that not one particular assessment is the standard assessment. It's a culmination of your interaction, your clinical interview, the family history, the biology, all the way back to when they were younger. Go as far back as you can through the development of the child. So if you have a high schooler, you're asking questions about the birth, the delivery, the milestones, the speech, the occupation, you're doing a whole complete piece. The school districts are very good about using speech pathologists and occupational pathologists when they're using through testing for autism. From what I understand, they do use a team approach, and that is so important. On the outside, if you're not involved with the school district, I would be using similar professionals to be able to say, can you please evaluate these areas that we're not able to evaluate so we can put this information together. But this is hopefully a clear picture of how much it does take. And there are different assessments that you could use that do measure the same types of things. It really depends on, again, budget, training, resources, and just preferences. Some people prefer this assessment over this assessment. As long as it's measuring the same thing, that's what's important. We really do like using the ADOS as well as the SRS. Those are the ones that Cornell and Harvard really pressed on, is being able to put that in conjunction with the other areas of clinical interview, social interaction, and those types of assessments to be able to overview whether or not there are enough information. One of the questions says, where does the aggressive behavior come from, such as biting, hitting, and jumping on people? Probably. That's very common. If you go back to some of the fact that they struggle with emotion regulation, sometimes even verbal expression, one of the things to remember, our board certified behavior analysts will always tell us that every behavior is communication. So they're communicating something to you, whether it's a social deficit or a sensory deficit or an emotion. So what we do is we teach our children and our adults and sometimes our teenagers how to express themselves, appropriately, so that they're not using verbal ways, or nonverbal ways, to do something that they can do verbally. So if they're frustrated or upset or they're angry, they learn to say, I'm very angry with you right now, instead of walking up to you and hitting you in the nose. Or if they're done and tired and don't want to do any more work, that they know how to say, I need a break, and that kinds of stuff. Because a lot of times their aggressive behavior is their way of communicating. So if you have a child or a teenager or even an adult in some cases exhibiting aggressive behavior, the first thing you want to do is kind of determine what's the trigger, where is it coming from, what are they trying to say or do. Once you can figure that out, it's going to be better, because you know how to teach them what they need. That life skill, you can't go up to somebody in public. I tell parents oftentimes when they're not addressing certain behaviors is, you're not always going to be here to speak for your child or take care of your child. One day you're going to go on, right, in age, in ability to keep up, and that person's going to be older. So if it's not okay for, a 10 or a 15-year-old to do it, you don't want them throwing an orange at you in the kitchen in the face, don't let the 4-year-old do it now, because 10 years later, that's how it's going to manifest down the road. So aggressive behavior comes from, I believe, their way of trying to communicate, their level of frustration or their level of intolerance, or they're not having a good time. So you've got to be able to figure out how to help them understand what they're experiencing. There's a technique that we call ACT, and it's ACT, and it's acknowledging their feeling. So if they're frustrated, saying, oh, I know you're really frustrated right now, you can't have the remote or whatever. And then that C, giving them, the boundary, letting them know what their choice is, not to, you can't hit me, but you can go hit this, or you can hit me, but you can do this instead. Being able to target that behavior some other way, because it's going to come out, we just need to give them the right channel. We have to be able to teach them how to release it. We don't want them to hold it in, but we want them not to carry people either. So aggressive behavior is an opportunity for them to learn how to communicate what they're feeling, and to be able to deal with the emotion that comes behind it. Usually does have a very strong emotion when you're talking about aggression. I think we have time for one more of these questions before we go to break. This is a very good question. I've also often thought of this. It says, what's the prevalence of autism spectrum disorder in science, technology, and the arts? I love that question. I think it's very high. Again, we have to be careful that we can't say everybody studying, science, technology, or arts and technology is on the spectrum somewhere. But sure, if we were to go into one of those universities, UT Dallas has a great program. I've walked that campus, and when I walk that campus, I'm amazed. Some of the thoughts that come to mind. I don't know what the prevalence is, but I find it to be very high, extremely artistic, creative people. My son is actually both of those. He's scientific and artistic. He's won awards and has been selling his art since second grade, just, I think, gifted in art. He told me once when we talked about autism on one of his rough days, he said, why did God make me this way? And I said, son, I don't know, but I think he gave you something special that he hasn't given everybody. And he said, well, if I had to give up my art, I wouldn't give up my autism, right? So he decides he's going to keep his autism because he wants to keep his art. So to me, they go hand in hand sometimes. I don't know why. I'm thinking, of course, it has to be with the way his brain operates and the way some of these individuals' brains operate. But I think those are gifts. I think that's how we play a big role in not only a parent, but also a professional in helping our children realize that everybody has limitations, but everybody has gifts too. I think we learn as much from our clients as they do hopefully from us. Developing that warm therapeutic relationship with the clients that are on the spectrum, with all of our clients specifically, but those especially that are on the spectrum who otherwise are not going to develop healthy relationships easily, is part of their healing process right off the bat. If you think about it for a minute, and somebody is in a abstract part of the world they've never been to before, they don't have a map, and they're just wandering, trying to find their place, and they find somebody friendly who says, where are you trying to go? Do you need any help? And that person gets them somewhere. That's you. That's you for the person who's trying to find their way socially or trying to find their way emotionally, regulating those emotions. That's you. And so if you're the only person that person is ever going to have to help them through that journey, that in itself is going to help them, regardless of what goals you've set forth. Sometimes we need to take a break from that, right? From that file and just really just have that connection. That's the big piece. So we're going to get back on track a little bit, and I'm hoping to get to these questions because I'm excited. I think that you guys are bringing up a lot of different questions that we need to be able to share, hopefully in a discussion format, ways that we're dealing with these things. So I'm going to do that. There are some topics that I didn't put in the PowerPoint that I want to bring up, and I wrote them on little index cards, so that's what I'm staring at. When we talk about the brain and how things work with our individuals that are on the spectrum, I find that some of those individuals, especially the ones that are older adolescents, 19 and 20-year-olds and older, lots of times, sometimes you get the younger ones too with this, but they'll realize something is different. They're struggling and they know they're lost, no different than that person in that different part of the world that's never been there. You know when you're lost, right? I know when I'm lost. And sometimes that child will say, I don't know how to do this. I try, nobody likes me. Everywhere I go, I've been to 5 schools. My mom keeps moving me around thinking it's the school, those kinds of things. We kind of have to stop all of that, and we need to have that conversation with the individual and let them know wherever they go, this is how they navigate. Whether their parents move them again, or they come back and see you, or they don't, give them those tools that they can use wherever they're, whatever environment they're in, because that's going to help them more than anything else. They need to know, how do I walk through this particular situation and come out on the other end? If they're struggling socially, start small. Our kiddos that are on the spectrum will walk up to a group of 5 little kids playing on the playground, and they want to fit in. They walk right into that group, and what do you think happens? They get that look. Remember that look you'd get when you were in 3rd grade? Like, who are you? That kind of look. So what I do is I coach them to go up to one person, not a group. That's much harder. Go up to one person. Maybe even go up to that one person who's playing with the roly-polies by themselves, right? Because then you can pair up, and now you have a friend. This is wonderful when they've made that connection with just one person and they gain that little confidence that they can do it. They're more apt to go to another person. Or maybe if they go to a person that does belong to a group of 5 or 8, and they match with that one person, that person will help them come into that group. But they shouldn't try to get in there alone. Those are the different skill sets that they need. When you're working with your individuals, find out what they want. Where are they struggling specifically? Don't assume they're struggling in all of these areas. Where to them in their perspective do they need the help? Do they want the help? And then start there. One of the questions that came up was asking about what the relation is with autism spectrum and bipolar disorder. Remember that peanut butter and jelly sandwich I told you about in the beginning? Those mood disruptions, I just see them, they're hand in hand. I've seen some of the sweetest kids that have autism, and that I'm talking higher functioning autism. They talk very robotically and all of those things. And sometimes they don't have a care in the world. They don't really get upset about too much. And when they do, it's very mild. And then there are some that just go into a full-blown rage, right? So we're looking at all these different individuals that have various different levels of disruption. When we're talking about bipolar disorder, it is prevalent. There are children that have autism spectrum that struggle highly with the mood disruption. And it can be everything from explosive, I'm gonna kill myself, I'm gonna kill you, I'm gonna chase you around the house with a knife, all of those kinds of things. As a clinician, what the first thing we want to do, of course, is to assess their safety and to be able to determine what's going on in the home, who the doctor is that's involved, putting a safety plan in place. We do a lot of safety plans with the kiddos that we get. Sometimes they're straight out of the hospital. We get them from SASH, we get some from here, we get from all over. But when they come to us and there's still some safety, that first 30 days we know about when they come out of a hospital, that first 30 days is that very, I don't know what the right word would be, but we keep a higher watch on them because sometimes they end up back into the hospital or they follow through with what got them in the hospital in the first place. So we're looking at them mostly twice a week when they first come out, and then after 30 days we'll go down to weekly. But those kiddos that have the poor dysregulation sometimes fall into that bipolar, and it's not uncommon to be able to see that some of these children struggle with hallucinations in times of stress. They might be 5th grade and 12th grade apart. Last time I hallucinated or went through something like this, I was still in elementary school, and now they're graduating senior and it's happening again. So we talk about episodic type of situations. Is there some mania prevalent? This is again where we go back with the physicians and we collaborate. Medications that they're on. Are they on an antipsychotic medication? If so, which one is it? And all those kinds of things. We're not physicians, but we want to know what's going on medically and have that communication with the physician. So in answer to that question, yes, I do think that there is a relationship to mood disruptions. Is it always bipolar? No. But can it be? Yes. There are different levels. Anxiety is mostly the more common one I see. Depression usually can follow. We have the philosophy that if you're struggling with a lot of anxiety and you're unable to do normal everyday living things, that can spiral you into a depression, right? If we take care of the anxiety, all the depression, dissipates because the anxiety got under control. Most physicians, I feel like conversations I've had with the ones we've worked with, like to really tackle that anxiety first because they feel like everything else will kind of settle down. And we see that there's some truth in that. And so I think that's a very important question about bipolar.